Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka, and we are recording this episode on July the 27th, 2020. As the COVID-19 pandemic continues, scientists are starting to learn much more about how COVID-19 can affect our health long term. Early research shows that the disease attacks more than just the respiratory system, affecting multiple organs with blood clots and inflammation. Here to discuss this with us today and share some information is Dr. Greg Poland, infectious disease expert and virologist. Thanks for being with us again, Greg, to enlighten us a little bit more about COVID-19.
Yeah, of course. We're learning something every week, so these are very valuable.
Well, it's wonderful to have you here. We know now and have known for some time that COVID-19 is more than just a respiratory disease. It has effects on many other parts of the body. Could you share with us a little bit about the long-term effects of COVID-19?
This is a disease, I think, that has a number of sort of mysteries involved compared to the usual respiratory virus. On the one hand, we see very severe but variable manifestations. We see a diminution of immunity over time. And then the part you're talking about, which is just sort of emerging, which is this idea of long-term complications. The term, and I'm not sure where it got started, has been long haulers, people who develop long-term and ongoing complications. Now, we've seen this with other viral infections, but not to this extent. I mean, we're really seeing a number of reports of people who report long-term fatigue, headaches, vertigo, interestingly enough, difficulties with cognition, with cardiorespiratory fitness. And I think what we're going to find out is that a large portion, not all, but a large portion of that is likely to relate to the significant cellular level damage that this virus can cause.
I would expect maybe to hear that for patients who have had a very serious illness. Perhaps they were intubated or hospitalized with COVID-19, but some of these effects can happen even in people who start with a milder case of the virus. Is that true?
Oh, very much so. And that's why I referred to it as kind of this mystery locked up in it. You think about, our normal everyday experience, let's say mild influenza, and the diseases are different, but mild influenza, you recover over a weekend, you're back to work, you don't think anything of it. But people with asymptomatic and mild disease, not just the severe, as you're pointing out, are reporting all kinds of problems. I have a friend, another ID doc, who got COVID-19, and he has experienced significant side effects. Hair loss, interestingly enough. It took about 2 months before he had enough strength to walk around his home. Those have resolved in him, and in other people, those have not resolved. So again, I think it's an argument for why we take this disease so seriously. People thinking, oh, especially young people, mild disease, I might not even have any symptoms and I'm over it. Whoa, the data is suggesting otherwise. Evidences of myocardial damage, cardiomyopathy, arrhythmias, decreased ejection fractions, arrhythmias, if I didn't mention that one, pulmonary scarring and fibrosis. And then in the more acute phase, extending out for a month or two, has been this really interesting issue of coagulation abnormalities, which have been responsible for both small vessel and large vessel arterial and venous occlusion. So this can be a really wicked virus in some people.
What is the thought behind why blood clots form in relation to COVID?
Yeah, our understanding at this point is that this is a virus that can stimulate a very inflammatory milieu. Not in everybody, but in many people. In fact, at its most extremes, we see two sort of syndromes. In kids, the multi-inflammatory system disease; in adults, so-called cytokine storm. And what happens is that this virus causes significant release of cytokines and chemokines, and in a sense overcompensates and actually tips us physiologically over into worse disease. By the way, something seen in the 1918 influenza pandemic. And so what happens is, whether it's cellular damage or enzymatic damage of other organs, for example, the liver or kidney, or stimulating coagulation, you see these things happen. One of the most frightening reports in my mind has been from many medical centers that have seen large number of cases. They are seeing large vessel occlusions in people in their 30s and 40s. I mean, devastating occlusions where a neuroradiologist will go in with a catheter to retrieve these large clots. And as they're pulling them out, new clots are forming. Really a devastating problem. One other point that I failed to mention about the long-term complications is hospitals that have seen a lot of cases are now recognizing that, if you will, the next wave of care for these individuals is going to be rehabilitation. And that's an area both on the physical and the mental side where, in general, American medicine, and I would say all of medicine, is understaffed. We don't have enough facilities to handle all the mental health and all the physical rehabilitation needs that this pandemic may well uncover.
Isn't that amazing? I usually think of rehabilitation of being someone's been in a motor vehicle accident and has
Exactly.
multi-injuries, or they had their joint replaced and so they needed to be rehabilitated. That's incredible.
I'm personally aware of some cases where one person's undergoing middle and inner ear rehabilitation because of vertigo after COVID. Other reports that I've read of people who have had difficulty walking. I don't know, we don't know yet if that's more of a neuropathic type issue or more of a stroke and small vessel issue. But a lot of things like that are going to require significant medical attention, and which are, unlike some aspects of medicine, are not particularly amenable to telemedicine.
Greg, you mentioned something earlier about long haulers or people who develop this sort of a chronic fatigue looking picture. Can you tell us a little bit more about that?
Yeah, there's a physician at Mayo Clinic who's done a lot of work in this area. And, it turns out that, when we use this term of chronic fatigue or long hauler, it is a recognition that of what you and I would recognize as a wastebasket diagnosis, meaning a lot of things fit in there. All the way from a physical illness uncovering a psychological problem responsible for symptoms, all the way to people who have validated, documented physical symptoms and everything in between. So how do you deal with something like that? Well, I think you deal with them all the same way. And you say, for any significant illness, there are mental and there are physical aspects to that illness. And we treat them both because they're both important and they're both valid. What will that treatment look like? I think it really is dependent on what kinds of pre-existing medical problems somebody has and what kind of symptoms or signs they're demonstrating now. But, this was declared a public health emergency of international concern mid-February, somewhere around there. So we're literally, we've got about 6 months experience, and that's it with this. And I think as we have larger and larger numbers, caseload in the US, and then people recovering as we've learned better and better how to treat them, we're going to see more and more of the longer term consequences come out. And we're going to need to study those as vigorously as we did the acute symptoms, catalog them, understand them, and then clinical trials to figure out how best to treat them.
You pretty much described whole person care. And certainly we know that there are other facets to someone's health than just their physical health. They're affected by their psychosocial situation, et cetera, et cetera. And that certainly, I practice pain medicine, and that's certainly something that we try to advocate in pain medicine, that we get you care for all parts of your life, not just your physical health.
You know, it's an interesting thing that you mentioned that, Helena, and I'll mention it on our broadcast here instead of privately to you. This colleague of mine, this friend, my same age, an ID doc, and I called him. He lives in another state, and he was tearful and said during the acute phase of his illness, he just wanted to die. And when I, talked to him about that, it was the overwhelming pain from the infection. He had just significant arthralgias and myalgias that they were having trouble keeping under control other than with morphine finally. So, it's just, again, a reminder that there are so varied manifestations in different people, and a reminder that none of us know what our clinical course would be if we were to get infected. And that's why it's just so important. And, in a sense, we're in the midst of a national debate about this. The distancing guidelines, the mask wearing guidelines, the hand sanitization guidelines are for all of our benefit, our children, our parents, our grandparents, and for us. So I do hope that people will begin to look at these caseloads. In 3 or 4 American states now, we're bumping up against 500,000 cases. I mean, this is just unbelievable. A new report just came out showing that when you look over the last 6 months, patients with cancer are dying about 12 times more frequently from COVID than from their cancer. And I thought about it in this way, and it's not quite a fair comparison. But if you could imagine saying to people, look, there's a virus circulating that could increase your risk of death 12 times higher than cancer, maybe they would take it more seriously. I don't know.
Yeah, clearly it's a great equalizer, isn't it?
Yeah.
Affecting all facets of the population, psychosocially, age-wise, and everything
Yeah.
else.
And I think people forget that the reason, not only do we have these guidelines to prevent getting infected, but when you do that, and we've clearly seen it now, the experiment's been done in multiple countries and multiple states. When you adhere to those guidelines, you dampen down disease and you push this off until we have a vaccine available. And if we can do that successfully, we're going to be freer, faster to to go back to the kind of life we all want to live.
I'm particularly intrigued by what you said about the pain of having this virus, because I have read some of what is out there. It has always been interesting to me that we sort of relegate, or in the past have relegated pain sort of as the last thing we will get to.
Yes.
That
Yeah.
we obviously need to treat the acute situation. If someone needs to be intubated, they need to be intubated. But pain associated with an illness or a procedure is really meaningful to the patient going through it, and a really large part of their experience.
I think the physicians that have been through whatever it is that might cause pain in their own lives are particularly aware of that. I'm very sensitive to it in my patients. And the hard part, and this really gets to your specialty, is how do we treat that pain appropriate, particularly as it gets to a longer term recurrent issue. And there's a lot of work to do in that area. So thank you for what you do.
Well, thank you. Greg, I wanted to go back to what we were talking about earlier. We talked about many organ systems that are affected. Obviously respiratory, cardiac, the vestibular system, most likely, etc. Is there anything known about why some people get those complications of COVID-19? Yeah. Is it a different strain of virus? Is it something genetic within ourselves? Do we know anything about that?
Yeah, you're asking the very question my research group has been asking. So we need to recruit you. Part of it has to do with the severity of the disease. The greater the inflammatory response, the greater the concomitant indirect effects on multiple organs occurs. The other thing is we are indeed strongly suspicious that this relates to the individual's genetic haplotype, or maybe it's specific high-risk alleles they carry. For example, you may remember reading early on, and I may not have the numbers exactly right, but this very sad situation of this Italian-American family, I think it was in New Jersey, where something like 6 out of 12 of them got sick and 1 or 2 of them died. Now, you would never expect that in a sample size of, say, 12 people. So clearly there's something genetic within that family, and we're hearing more case reports of that. Our own group is getting ready to do a study where we want to study the genetic haplotypes of those families that have had unusually severe disease and that has affected multiple members of the family. So I think we are going to find that that's a part of it. Disease severity, genetic predisposition, and you wonder, particularly in the beginning of the outbreak, where there are some unproven treatments that undoubtedly make this worse. And that's the reason for having good, high-quality clinical trials to understand this.
So my last question for you, Greg, is something that's of particular curiosity to me. I'm familiar with some cases, even here, from some of our employees at Mayo Clinic, where the patient has developed COVID-19, had a positive test, been quarantined for the appropriate period of time, and then they need to have a negative test to come back to work. But they keep having positive test after positive test after positive test.
Yeah.
Why is that? Are those tests wrong?
That is $1 million question, isn't it? And not only that, but some cases in which people had COVID symptoms, had positive PCR, recovered symptomatically, had negative tests, then developed symptoms again in association with a positive test. Our first impression is to say that that's reinfection, and that is one of the diagnostic possibilities. The other possibility is that the PCR test is wrong, that there was a sample mix-up, and no test has perfect 100% sensitivity and specificity. I don't think that's going to turn out to be the majority of the cases. Another possibility, and actually this was true in a resident of mine who excreted virus in his stool for weeks and weeks on end, is we may just be detecting residual viral genetic material. In other words, the PCR test tells us genetic material is there. It doesn't tell us transmissible infectious virus is there. Because that would require culturing it, which of course would be a very dangerous thing to do. You'd have to do that in a BSL-3 type environment, and very few places are equipped to do that. So I think that has turned out, exactly as you said, to be an area of very active investigation. Is there chronic disease? We've never seen that with the coronavirus in terms of chronic infection. Are these diagnostic issues with the assay? Or have we simply developed such exquisitely sensitive assays, and that's what I think is going on, that we're detecting residual genetic material, or combinations of all three of those?
That's really interesting. My personal goal is to learn something new every day. And I have to say that every day that I get to meet with you and do this broadcast, that I learn several new things. So thank you for contributing today.
I think that's true for all of us, as I've said, and I think it's fair for us to be really transparent, is that we are building this airplane while we're flying it. We're learning things every single day. And really, I think it is just astounding when I look at what every specialty in medicine at Mayo and around the world, how they're collaborating, and the amount of publications and studies being done. It is unprecedented in the history of mankind. And so I'm hopeful that, if we pull together, we use evidence-based medicine, and we use high-quality clinical trials, we will get this under control sooner rather than later, and in a way that helps, not harms.
That's wonderful. Thanks for the encouraging words.
Yeah.
We thank Dr. Greg Poland, our infectious disease and virology expert, for joining us again today. And thanks to each of you too. We wish you a wonderful day and stay well.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.